32.
Sir, please start the session.
Connection is unstable. Okay. अरे मेरे को लगा करिश्मा आई. अच्छा, but baby आया? Zuri नहीं आई?
I'll be back.
We are live. Please start.
Okay.
Should I start, sir?
Hi Rishma.
Hi,
ma'am.
Rishma.
Hi, madam. Welcome, madam.
I couldn't join. So yeah.
Good.
Full quorum.
Rishma ने भी लाइट एडजस्टमेंट बराबर किया है. वेलकम टू नागपुर रिश्मा.
From half of Maharashtra, it's like full on Maharashtra's here. That's good. Yeah.
That is credit to Nandita. Amogs में she is really doing wonders.
Actually, really.
Hi, Rishma.
I've got fabulous chairpersons here.
Hi, Mohan. Hi. Hi. So good to see everybody. Full attendance, Asa.
We can start the session. We are live.
Right.
Okay.
Good evening, everybody.
Hello, Pandit. Good evening, Pandit. Sir.
Hi, Pandit.
Hello, sir.
Can we start the screen sharing, and Ameya, can you start the session?
Yes, sir. You can please.
Can you have the screen?
Varsha, please share the screen.
Yes, sir. Am I audible?
Yeah, Ameya, you can start.
A very good evening to all of you. On behalf of Amogs Infertility Committee, in association with OBGY Society of Mumbai, Nagpur, Aurangabad, Amravati, Solapur, Nasik, Chandrapur, Satur, I welcome one and all to this Ek Shaam Amogs Ke Naam webinar on RPL, recurrent pregnancy loss, experts experience. We have 3 wonderful talks followed by a star-studded panel discussion. Today we have with us eminent stalwart from across the country. So I can assure you that it's going to be a power-packed evening. So without wasting any further time, I would like to invite conveners for tonight, Dr. Chaitanya Shembekar sir.
Good evening, friends. Ek
Dr.
Shaam
Chaitanya,
Amogs Ke Naam. Yeah.
Sir is the past president Nagpur OBGY Society. He is the guide and mentor Omega Hospital Nagpur and is the chairperson Amogs Infertility Committee. Yes, sir.
Yeah. Good evening,
Varsha,
friends.
kindly make it full screen. Sorry, sir. Kindly make it full screen, please.
Ek Shaam Amogs Ke Naam. Today evening, Infertility Committee Amogs, under the able leadership of Dr. Nandita Paishetkar, is presenting before you a webinar on RPL and infertility. We are fortunate to have with us Dr. Nandita Paishetkar. She is past president of Foxy and dynamic president of Amogs, and Dr. Rishma Pai, past president of Foxy and president Emogs, as guest of honor. Welcome, Dr. Nandita, Dr. Rishma. Infertility Committee of Amogs has done wonderful work this year with publication of book and guidelines on COVID-19 and almost 6 to 7 webinars in last 6 months. Thanks to Dr. Rohan Pashetkar and Dr. Nilesh Balkavade for all the support. I take this opportunity to thank Bharat Serum for the educational grant and all the support they have given us through this webinar. The specialty of today's webinar is that we are going to discuss very specific topics as to how I do it, where the speakers will talk about the way they treat particular condition. We are fortunate to have involvement of so many societies from Maharashtra with masters in the field of RPL, that is Dr. Mala Arora, Dr. Lakshmi Shrikande, and Dr. Parag Beniwale, Dr. Mohan Raut, and many seniors with us. This webinar is going to enrich us with the latest updates on this topic. So once again, I welcome you all. Sit back, relax, and enjoy today's evening. Ek Sham, Amogs ke naam. Thank you. Thank you very much.
Next, I would like to invite Dr. Nilesh Balkaude, the co-convener for this evening. He is the most humble personality of Pune Obstetric and Gynec Society, the Joint Clinical Secretary, Pune Obstetric and Gynec Society, Chairperson elect Foxy Quest Committee 21. I would request Dr. Nilesh Balkaude to invite our guest of honors for tonight, Dr. Nandita Palshetkar Madam and Dr. Ishma Dhiran Pai Madam. Over to you, sir.
Thank you, Amey, for the kind introduction. At the outset, I would like to thank Nandita Madam, Team Amogs, and Chaitanya Shembekar sir, Chairperson of Infertility Committee, for making me this co-convener for this wonderful program on RPL today. And can we have Nandita Madam's slide, please, Varsha? So I'm introducing none other than Dr. Nandita Palshetkar. The beauty in a woman is reflected in her soul. It is the caring that she lovingly gives, the passion that she knows. Words will fall short to describe the woman of this stature, Dr. Nandita Palshetkar. She is the President Amogs 2020-22. She is the past President Foxy, past President of Mumbai OBGY Society, President IIG in 2017, Vice President ISA to 2020, and the most wonderful human being going at this stature I have seen, and still caring for all their Amoxians and Foxians. Welcome, madam, for your speech for today's program.
Thank you, Nilesh. I don't know whether my internet
You're audible, madam, but it's just slightly breaking.
Can you
So
move
on
the
behalf of
visibility so we
Amogs, I
can
would
see her?
really like to welcome
Can you stop the screen share so we can see her? Stop the screen share.
Hello.
Yeah, Nandita ma'am, you are audible now.
Yeah, okay, because I think my internet is unstable. But on behalf of Amogs, I would really like to welcome everybody. It's a fantastic job which my, infertility committee chairperson, Dr. Chaitanya Shembekar, has been doing. And, it's amazing the way Amogs is energized. I think the COVID has brought out in us all our innovativeness, and we are reaching out to each other, we are teaching, there's fellowship, and I think this beautiful name, Ek Sham Amogs Ke Naam, is wonderful idea, and Chaitanya, I'm really happy that you're doing it. And I would like to welcome Rishma, who's a very good friend, and we've, I think, grown up. She's a wonderful so I think all the presidents are full of energy and getting everything done. So welcome, Rishma, and I'm happy to have you as our guest of honor over here. And of course, all my friends. I mean, I can't see it. Nilesh is doing a wonderful job. Nilesh and Rohan are the co-conveners with you, Chaitanya. There's Parag, there's Lakshmi. Then I think the speakers, Mala, it's good to see Mala and Mohan from Bombay. So I think, Chaitanya, I will not take much time, but I just want to tell everybody that we are having the AGM of Amogs on 4th October, and we would definitely like a lot of representation from all the societies. So I'm very happy that, you all are coming together, we're working as a force so that, it becomes very popular, and Amogs can become national also. Thank you. Thank you very much.
Thank you.
Thank you, ma'am, for your wonderful insights about this program. And as usual, we love to hear you. A note about Rishma, madam. Strong women wear their efforts, their pain like stilettos. No matter how difficult it is, all you see is the beauty of it. And I think Rishma, madam, represents that. She's a wonderful human being, wonderful lady. And she's the president of Mumbai Obstetrics and Gynecological Society. We have seen as a wonderful, dynamic, foxy president as well. and she's a past president of all leading national bodies like the ISAR, IAG, assistant treasurer of the IFFS. I welcome Madam for your note as a guest of honor.
Thank you. Thank you so much for the warm words. We have a lot of echo in the background. If we can mute the other people who are not speaking. And if I can just have the screen share removed. Can we shut the screen share, please?
Dinesh, yeah, Varsha, please, yeah,
Not a
that's
disturbance.
fine.
Thank you. Good evening to all of you. Thank you, Nandita, for inviting me and for the wonderful, warm words. Thank you, Chaitanya. I mean, truly, really fabulous program planned. Thank you, conveners. Thank you, Nilesh. Thank you, Rohan, and for this entire team of Amogs. In fact, yesterday somebody called me to say that, have you got the link for the Ek Shaam Amogs ke Naam? And to me, I thought it's some kind of a musical program because the name is so musical. I was like, yeah. And I put down the phone, not even connecting with the fact that this is the program. And I was really confused. And then I realized, oh my God, this Ek Shaam Amogs ke Naam is a hardcore academic program. And I think what you have done is really put such fantastic speakers together that probably the academics is going to be like music to our ears. So that's probably the connection that happened. And finally, it struck me that that's the logic behind this whole thing. So I think that was well thought out, and it was really, really interesting because it drew everyone's attention. All of us know that, like Nandita mentioned, in these COVID times, amazing things are happening which have never happened before. And I think the stage has been taken by Amogs, because I can see Amogs doing some unbelievable, amazing work, and having brought together every single society of Maharashtra and across the country. I've seen South India joining in with Amogs. I think it's been really, really wonderful, and everyone's really making an effort to take forward this organization called Amogs. And I think it is credit to the leader, because the leader has to choose the people who will lead it forward. And Nandita, being an expert at leadership, too much experience in the past with that, I think is doing an excellent job. So really amazing that Amogs has really become so vibrant and so lively. I actually will stay back and hear these lectures, because to me, recurrent pregnancy loss is a really difficult subject. Having heard a million talks on it, read so much, I think still confusion, starting from the definition to the tests to be done to the treatment, of course. And you really managed to get together experts in the field. I think all the speakers have years and years of experience behind them. So it will really be worth listening to for all of us, though we've been working in this area also for many, many years, but there's lots to be learned. So I'm just going to show you something I read very recently, and it made a lot of sense to me. It says that the dilemma of modern medicine is the irresistible drive to do something, anything. It is expected by the patients and too often agreed by their doctors. And this is what really worries me, the desperation that kuch to karo. And many times, instead of doing good, we may end up doing harm to the patient, because all of us know that in RPL, half the cases are unexplained and half the cases there's nothing that you can do. So I look forward to hearing practical tips today on what we should do so that we end up doing good for the patient and definitely no harm to the patient. So thank you all for inviting me, giving me this honor, and really look forward to all of you having a wonderful CME today. Congratulations for bringing everyone together. All the very, very best. Thank you.
Thank you, ma'am.
Thanks.
Now to start, we'll start with the talk.
I think just 1 minute, there's Nilima here. We must appreciate Nilima who's here. Then I couldn't see everybody. Vaidehi, there's Pandit, and who else is there? Kiran is there. Anjali is there. Anahita has just joined in. So I think welcome on behalf of Amogs. Initially it was difficult to see.
Yeah, Amogs, ma'am.
Kalyan is there somewhere, I think. Okay.
Varsha, can we mute everybody except Ameya? Now he wants to start.
Okay, sir.
Yes. We start with that talk. For the first talk, I would like to invite the chairperson, Dr. Vaidehi Marathe. Can we have her CV?
Yes,
Varsha, can we have her CV? Dr. Vaidehi Marathe.
yes, sir.
Ma'am is the director, Mahir Maternity and Nursing Home, Nagpur. She is a president, Nagpur OBGY Society. Ma'am is the winner of MS Signature International Award. She is doing passionate work in various social awareness campaigns and programs for women. I would request Dr. Vaidehi Marathe ma'am to introduce the first speaker for tonight.
Thank you so much, Amay. Thank you, Amogs, for giving us this opportunity to chair today's session. Today, we have with us a very distinguished speaker, someone I have always been in awe of, Dr. Mala Sibal, an outstanding academician with tremendous work in the field of miscarriages and an orator par excellence. It won't be an exaggeration if I say what Sachin Tendulkar is to cricket, Dr. Mala ma'am is to the area of miscarriages. And incidentally, she is the Sachin Tendulkar of today's session as well, the opening batsman. And I'm sure it's going to be a super knock. Mala ma'am's credentials are extraordinary. She was the chairperson ICOG 2017, vice president Foxy 2011, and she has authored many books, especially related to today's talk. She has been the chief editor of RPL and World Clinics in OBGY. She was the editor-in-chief of Yearbook of OBGY and many more books. She's been the peer reviewer of British Journal of OBGY as well. Her biodata is so long, maybe I'll take the entire session if I have to introduce her. So I'll just cut it up. I'll just cut it short, and I welcome ma'am, Mala ma'am, the authority in RPL. I invite her to deliver today's deliberation on my way of using LMWH in RPL. Welcome, ma'am.
Thank you so much, Vaidehi. It's a pleasure to see you as my chairperson. And thank you for the lovely introduction. I'll go straight to sharing my screen. Can I do that now? Yes. I think, Chaitanya, you have planned the talks very nicely. And I must congratulate you for choosing these topics. Let me get to the first slide first. Yeah. So low molecular weight heparin is something that is never discussed because we think we know everything about it. And I think when you gave me this talk today, it gave me the opportunity to do a lot of literature search on this. But before I go on to the topic, I must for a moment stop and say we all need to pray for the world, especially for the doctors that are frontline warriors, the patients that are fighting COVID in ICU, and the increasing number of people that we see now get affected. Let's hope God has mercy on India and we can fight the disease. I bring you greetings from the Indian College of Obs and Gynae and Noble Hospital and IVF Center. And through this journey of RPL, which started almost in 2020, I have seen a lot of changes in the field of RPL, but very little change in the use of low molecular weight heparin. Yet, when I put this talk together, I realized that I have to emphasize here that heparin is the most used, but also the most abused drug in RPL. I'll take you through a little bit about heparin, and very few of us use unfractionated heparin, which is also a wonderful drug to manage your patients with RPL who cannot afford the high cost of low molecular weight heparin. The only disadvantage of unfractionated heparin is that it needs to be injected twice, 5,000 units given morning and evening because it has a shorter half-life than low molecular weight heparin. But the advantage of using unfractionated heparin is that it has a beautiful antidote called protamine sulfate. And so a lot of people who have patients on low molecular weight heparin want to shift to unfractionated heparin when they go into labor and they are at a high risk of thrombosis. Because whenever you need, you can inject protamine sulfate IV and reverse the effect of heparin. The disadvantage also is that you have to check the platelet count because it is associated with heparin-induced thrombocytopenia in a very small number of patients. But of course, the bigger problem with heparin is osteopenia. And I think, please, for a moment, stop and think, when you have a patient of RPL who will try and be on bed rest because she's worried, and you give her heparin, if you don't emphasize leg exercises, calcium, vitamin D3, she may have osteopenia. So when we come to low molecular weight heparin, which all of us are very familiar, we have two salts. One is enoxaparin, which we give in a dose of 40 milligram or 60. And the other is dalteparin, which we give in 5,000 units. And it can be given once in 24 hours. But the disadvantage is it has no antidote. Monitoring is not required, and this is a very big advantage because you don't need to check her platelet count, you don't need to check her clotting screen or APTT. But if you want to use it in a therapeutic dose, in somebody who also has a DVT, you have to up the dose to 1 milligram per kilogram, which would mean at least 60 milligram of enoxaparin, if not more, or 100 units per kilogram of dalteparin, which would mean at least 6,000 or 8,000 units, depending on your patient's weight.
Findings and intraoperative, like how it goes. If cesarean goes well, patient's HP is good, then it is
The thing is that the osteopenia, although is a side effect, there is no risk of thrombocytopenia.
If you have to transmit blood,
One important thing I want to emphasize is that these anticoagulants have a powerful complement inhibiting action.
Usually not very much because
The support, Ame, can you request the support team to mute everyone, please?
Varsha, can you please mute the other audio?
CBC and all the investigations we do just
Varsha, keep everybody muted except Mala.
Okay.
Mute everyone except ma'am.
Okay, sir.
So the important thing which we don't realize is that these heparin is not only just an anticoagulant, but it has a very powerful complement inhibiting action. And this dual action of complement inhibition and anticoagulation makes it the perfect choice for APL syndrome and RPL. So here, if I present to you this chart, then those anticoagulants like unfractionated and low molecular weight heparin that have a strong complement inhibiting action are the only ones you should use. Those like hirudin, fondaparinux that don't have a complement inhibiting action are useless in APL syndrome. Now, prothrombotic states in pregnancy are two. One is the inherited thrombophilia, which you all know about, protein S, protein C deficiency. And the other, and by far more common, is the antiphospholipid syndrome, which can be primary or secondary to an autoimmune disease. So let us first discuss antiphospholipid syndrome. There are only 2-3 points I need to emphasize: that you must do a battery of all 3 tests. Very important to
the next question.
Very important to include anti-beta 2 glycogen 1 and 1, IgG and IgG, because these antibodies, if positive, have a poorer pregnancy outcome. Treatment is with heparin, as I just said, and aspirin.
Ma'am, can you hold on, Chaitanya? Can you please look into this audio issue? People are not muted and we are not able to hear Madam well.
Can you mute her?
Varsha, please mute everybody. Are you not able to mute everybody, Varsha?
So I am muting everyone, but they are unmuting it.
No, so you say, keep the setting off. No, don't allow others to unmute themselves. You can change the
No
setting.
problem.
You
Okay.
keep it. The control should be in your hand.
Okay. Is it okay to start, Vaidehi?
Yes, ma'am.
Yeah, thank you. Yeah, that disturbance was a bit. So now we are looking at the criteria for diagnosis of antiphospholipid syndrome, which you all know, one clinical and one laboratory criteria. However, abruption is not a defining morbidity of antiphospholipid syndrome. That is an important point to note. I cannot move my slides now. Somebody has. I'll have to stop and start screen sharing. Okay. I cannot move my slides. Something
Varsha, can you
difficult.
look into this?
Doctor, use the arrow below.
Yeah, I'm using.
There's,
Okay, now it is done. Okay. So there are three important things that happen with antiphospholipid syndrome and RPL. One is uteroplacental thrombosis, so we need an anticoagulant. Second is adverse effect on trophoblast with its decreased viability, and so you have late pregnancy complications. And third is an inflammatory response in the placenta, as happens in all other autoimmune diseases. So here you can see in APL syndrome, this is a normal patient whose syncytial trophoblast is completely filling the maternal vessel and bathing in maternal blood and having good placental transfer. And this is an APL patient in which the maternal vessel has a thrombus and the syncytial trophoblast cannot penetrate through this vessel and cannot have good placental transfer. Then you have increased placental apoptosis and decreased trophoblastic invasion. So the placenta is actually not functioning well. And lastly, it has a disordered immunology with high NK cells and a complement reaction, which further damages the placenta. So reminding you again that we use heparin because it attacks both these problems and so is the best suited. We have to monitor APL syndrome for further complications in pregnancy once the miscarriage risk is over. And that is hypertensive disorders, fetal growth restriction, oligohydramnios, and it is recommended that you deliver them at 38 weeks and don't take them to term and beyond because they have a higher risk of complications. However, before delivery, you need to stop aspirin for 7 to 10 days before delivery, and you can switch from low molecular weight heparin to unfractionated heparin 6 to 8 hours before delivery. But most important on this slide is, please don't forget to give them thromboprophylaxis in the postpartum period, because that is what gets missed out many times and they get an unnecessary DVT. We already have enough evidence to say that aspirin alone has a poorer outcome as compared to aspirin and heparin. So this graph shows you no treatment gives you a 10% live rate, and giving only aspirin gives you a 40% live birth rate, and giving both together almost doubles it to 71%. The aspirin dose is 100 to 150 milligram. We usually stop it at 36 weeks. The low molecular weight heparin can be started either in the luteal phase of an ART cycle or as soon as a pregnancy test is positive. We don't normally wait for a fetal heart to appear because that was the old guideline. The good thing is that it does not cross the placenta, and so there is no fetal anticoagulation. We always prefer low molecular weight heparin because of the reasons I just discussed. But there are special situations where you may have to use warfarin, If the mother has had a DVT in her previous pregnancy, you will need to switch her to warfarin after the first trimester is over. And if she develops a heparin-induced thrombocytopenia, then a new drug that we can use is danaperoid. And I will come to danaperoid in a little more detail. It is a non-heparin anticoagulant. It is classified as a pregnancy category B drug. It does not cross the placenta, and animal studies show that there is no fetal toxicity, but there are no human studies so far. It is given in a dose of 750 units subcutaneously twice a day, and it is specially indicated in women that get heparin-induced thrombocytopenia. There are a few case reports in literature where it has been used throughout pregnancy, and it has shown good maternal and fetal outcome. However, larger studies are still awaited. So we have two types of anticoagulant doses. One is prophylactic that we all use, which is 40 milligram, as I said, and the other is therapeutic, which is a higher dose. And when you give the therapeutic dose, you must monitor APTT and keep it 1.5 to 2.5 times the control value. So when you go on to a therapeutic dose, you need to monitor the coagulation parameters. In a prophylactic dose, there is no need for monitoring. We have discussed this, and taking you further for monitoring, before you start low molecular weight heparin, you must have a baseline hemoglobin, hematocrit, platelet count, and serum creatinine, so that you can compare, is there a drop in the platelet count? Creatinine is important because the dose of heparin has to be modified in patients with compromised renal function. So there is something called a renal dose of heparin, which you will give if somebody has chronic kidney disease. So we monitor the unfractionated heparin by APTT, and it should be 1.5 to 2.5 times. But for low molecular weight heparin, we don't need any monitoring, but we can do a factor 10A activity 4 to 6 hours after starting the dose and maintain this between 0.6 to 1 units if we want complete safety. This is again for the therapeutic dose of low molecular weight heparin. During labor, we want to switch to unfractionated heparin. We want to keep protamine sulfate ready if she's on therapeutic doses. And this is given as a slow IV infusion, a total dose of around 50 milligram, infused slowly over 10 minutes. We preferably stop unfractionated heparin 12 to 24 hours before a cesarean section, and we can give a spinal and epidural 12 hours after a prophylactic dose or 24 hours after a therapeutic dose of low molecular weight heparin. If this criteria is not met, she should have a general anesthesia because you don't want to take the risk of a blood clot in the spinal canal. You can safely reinitiate heparin 12 to 24 hours after a cesarean section and continue both aspirin and low molecular weight heparin up to 6 weeks postpartum. And the complications, which we have already discussed, are thrombocytopenia and bone loss. Now, one important point that I have to emphasize, most of us are using empirical heparin and aspirin in unexplained RPL. And then we realize that we have used it and the patient still miscarries. So it is very important that we realize that this Cochrane review that came out in 2014 clearly said that there is no role of heparin in unexplained RPL, because majority of your unexplained RPL are either genetic or infective, and heparin is not going to prevent that. So if we look at RPL, there are 3 factors that are now going to shorten the amount of unexplained RPL you see. Currently we say 50% is unexplained, but if you do a genetic test, CGH microarray, if you test for autoimmunity with ANA, and if you check for infection, then this group of unexplained is shrinking fast. That's the good news. So This is a paper from USA, published in 2018 in Human Reproduction. And they said that if they did a 24 chromosome CGH microarray on all patients that miscarried, they found a cause of pregnancy loss in over 90% of the patients. So please don't give heparin and aspirin in unexplained. Try and do their CGH microarray. The next question comes, what if there is a patient of APS syndrome? You have given her heparin and aspirin, and she then miscarries again. Have you faced such a situation in your clinical practice? I'm sure most of you have. So in these situations, there are two molecules that appear promising. So one of them is hydroxychloroquine in a dose of 200 to 500 milligram, and it should be started, it can even be started before pregnancy and continued during pregnancy. There is evidence building up that HCQ directly reduces the binding of beta-2 glycoprotein to the phospholipid bilayer. And it is definitely recommended in patients who have SLE or autoimmune secondary APLA. But if you have a primary APLA syndrome, this paper, which was published in 2020 April, has done a pilot study or randomized open label pilot study which said that HCQ gave a better outcome when it was added to heparin and aspirin. So this is a molecule you can keep, and it has been enough publicized during this COVID time. We all know about HCQ prophylaxis. So now you are not afraid of using HCQ. So we are going to have a big randomized trial on HCQ in RPL, and those results are expected in 2021. They're still not out, but the pilot study shows good results. And the second molecule is IVIG. So IVIG in a dose of 0.4 grams per kilogram body weight is indicated in APLA syndrome if aspirin and heparin do not prevent a miscarriage. Again, IVIG does not work in unexplained RPL. And many people phone me and tell me that they had a patient of unexplained RPL and they gave her IVIG and it didn't work. So I tell them that unless you do a genetic testing, you're not going to solve the mystery of unexplained RPL. And lastly, we need to touch inherited thrombophilia. The evidence that inherited thrombophilia is associated with RPL is not clear. Most prospective trials say that it is not associated with RPL, but retrospective trials have confirmed an association. So we are still struggling to find out whether it is associated or not. However, if there is somebody who has inherited thrombophilia and gets pregnant, she needs a therapeutic dose of low molecular weight heparin and aspirin. But if she has unexplained RPL and no previous thrombosis and has just got a thrombophilia screen positive, then the value of giving her anticoagulation is still doubtful. Autoimmune diseases are increasingly being implicated in unexplained RPL, and an ANA titer of more than 1 in 160 is supposed to be diagnostic. And this is a very recent meta-analysis in 2020, which said that ANA positivity was higher in RPL patients. And these patients will then need treatment of their autoimmune condition with steroids, but there are studies which are saying that there are thrombogenic antibodies seen in patients with unexplained RPL. And this was a study done in Japan. I'm sorry. And they studied 227 couples, and they found that this unique antiphospholipid antibody was positive in 24 out of 121 cases of unexplained RPL. And these antibodies also led to thrombosis. So a lot of new things are unfolding. And one new test that will come in your armamentarium is thromboelastography. Thromboelastography is a simple test where you put some citrated blood into a cup and then oscillate the cup and see the formation of the clot, and then how long does it take for the clot to lyse. So you're not looking at clotting factors, but you're looking at two pathways. How long does it take for the clot to form, and how long does it take for the clot to rise? And if these two are deranged, then you can choose which patients will need heparin. So this is one test which I think will need more investigation in RPL. It is definitely used in a lot of ICUs as a bedside test to see if they need anticoagulation. But we are not still using it in RPL, and I would urge anybody who has the facility to please investigate it in RPL. And as a summary, we have discussed all this about antiphospholipid syndrome. There are a few guidelines that you can read, and these are on the slide here. These are all discussing antiphospholipid syndrome and the use of heparin. And the take-home message is that you have to have a positive test before you give them aspirin and heparin. I cannot emphasize that more. Thank you very much.
Thank you so much, Mala ma'am. This was such an excellent presentation. You have very clearly outlined the rational step-by-step protocol of using LMWH in patients of RPL. Just what is required by all of us as treating obstetricians. One very important point as a take-home message that you told us not to start aspirin and heparin unless the investigations are positive. Thank you so much, ma'am, once again for explaining the unexplained so very well. We really have very clear take-home messages today. Thank you so much.
Thank you so much, ma'am, for the wonderful talk. Thank you, Vaidehi, ma'am, for chairing the session. For the next talk, I would like to invite the chairperson, Dr. Kalyan Barmade. Can we have the slide? Sir is the chairman, Latur Fertility Center. He is the president, Latur OBGYN Society. He is the president, Latur IMA AMS 2020-21. And he has organized various conferences in Latur and Aurangabad. I would request Dr. Kalyan Barmade, sir, to invite our next speaker.
And sir is also standing for the treasurer post of IIG.
Thank you, Nilesh, for that kind introduction. I'm really happy today to get invitation from Amogs family. Thank you, Dr. Chaitanya and Dr. Nilesh. Can I have CV of Dr. Mohan Raut, sir, please? Mohan Raut, sir, is a consultant gynecologist and obstetrician in Mumbai. He's a partner of Dr. Raut's Center for Reproductive Immunology, partner of Dr. Raut's Women's Hospital, trustee of Raut's Immunotherapy Foundation. And in 1992, Dr. Mohan Raut involved in the International Multicentric Research Program in association with Oxford University on the role of active immunotherapy in recurrent miscarriages. He had involved in active immunotherapy program, that is HIT therapy in Mumbai, which is really successful. He has contributed a chapter in immunotherapy in repeated miscarriage in the book Pregnancy at Risk, Current Concepts, published by Foxy. He has published papers and has spoken in national and international conferences on the topic of immunotherapy in repeated miscarriages. He has started India's first immunotherapy center, recognized by DCGI, with Dr. Mrs. Mugdha Raut, and he's writing a book, Immunotherapy in Repeated Miscarriages and Implantation Failure, New Horizons, with Dr. Mugdha Raut. We are really looking forward for this book to come in the market. Welcome, Dr. Mohan Raut, sir, for your talk. Welcome, Dr. Mohan Raut, sir.
Mohan, I think you are muted.
Thank you, Dr. Kalyan, for your kind introduction. And I am really thankful to Amogs for inviting me here for this webinar and to speak on a topic on LIT or lymphocyte immunization therapy. It's really an honor to be a part of Amogs webinar, especially with such illustrious speakers and panelists. And it's really pleasure to be here virtually in Nagpur. So I will upload my presentation. Great. So I'll begin my talk on role of lymphocyte immunization therapy in repeated pregnancy loss. The topic is little different. It's unusual. And let's see what happens in next 20 minutes. At the end of 20 minutes, whether I'm successful in giving you a different vision on this different subject in the field of RPL. In the beginning, I have to express my gratitude to my teacher, Dr. Usha Krishna, because of which I am in this field of reproductive immunology. And of course, my wife, Dr. Mugdha, who is a member of Education Committee of American Society of Reproductive Immunology, because of whom we have our center, Dr. Rouse Center for Reproductive Immunology. So let's begin our talk today, lymphocyte immunization therapy. What is LIT? As the name suggests, it's use of allogenic lymphocytes to induce immunomodulation in patients who have repeated miscarriages and recurrent implantation failures, especially the unexplained one. Why I'm talking on this subject? As Dr. Kalyan said, I have been working in this field for almost more than 28 years, and I was part of a double-blind multicentric study of Oxford University on the role of LIT on RPL with Professor Redman, who was the main person, and with Dr. Usha Krishna. And I have been associated with more than 1,000 LITs, and we have our own Center for Reproductive Immunology in Mumbai. The scope of my today's talk is something like this: why LIT should be considered, how does it work, how we select couples for the therapy, what is the procedure, what is the follow-up and the post-procedure advice, the safety of the procedure, the efficacy, and of course, the controversies related to it. That the incidence of miscarriage increases as the number of miscarriages increase, and the total women affected by this problem of repeated miscarriage can be as high as 2 to 5%. And there are various causes, but unfortunately, almost 50 to 60% of cases, there is no cause found. As Dr. Mala said, that this number is shrinking because of the advanced genetic investigations, but still a significant number will remain where we can't find the cause, and this can be explained by the alloimmune problem. The same thing is with implantation rate. Implantation is an inefficient process, and the maximum implantation rate is 40 to 60% according to Reinhardt. But in last week's POGI webinar by Professor Ben Raphael said that the implantation rate can be dismal, close to 18%. So the implantation failure in ART goes to up to 82%. So that's really high. Most patients who undergo IVF will end up with recurrent implantation failure, according to Kaufland, though there are variations from 5 to 25%, but definitely close to 20%. So is there any possibility of a different factor which can explain this etiology in these conditions, alloimmune factor? Is there any role of immunomodulation in these patients? Or to be specific, can active immunomodulation with lymphocyte immunization therapy play an important role? Let's see what we get in next 20 minutes. So all of you are aware that fetus is a semi-allograft. It is the embryo and the gestational tissue expresses foreign antigens derived from different maternal and paternal chromosomes, and therefore pregnancy is 50% different from mother, but it grows without any problem, without any rejection, underlining the immunological paradox of pregnancy. But the more important thing to understand why we should consider immunomodulation is this figure, which shows the various type of lymphocytes or cells which play an active role in maintenance of pregnancy. The Th1 and Th2 type of, all of you are aware that Th1 are inflammatory cytokines producing cytokine producing cells, and Th2 are anti-inflammatory cytokine producing cells. But the more important combination is the Th17 cells and the Treg cells. Why they are important? Th17 cells are pro-inflammatory while Treg cells are anti-inflammatory, but their importance lies in the fact that they are interconvertible. We can convert Th17 cells to Treg cells to suppress the inflammatory action, and this can be achieved by immunomodulation. So it is at this level of conversion to Th17 to Treg cells where immunomodulation plays a role, especially the lymphocyte immunization therapy. So that's why we should consider lymphocyte immunization therapy in these patients. How does it work? The exact mechanism at the molecular level, how LIT is working, is not clear. Research is on, but there are certain things which are put forward. Is the development of, first is the development of blocking antibodies. These are the asymmetric antibodies which protect the pregnancy. You are aware that there are something called as symmetric antibodies which are responsible for the rejection of pregnancy, while these asymmetric antibodies competitively inhibit the symmetric antibodies and prevent the rejection of pregnancy. And this development of blocking antibody is induced by the lymphocyte immunization. Also, there is Treg cell activation through lymphocyte immunization therapy, which I mentioned just now in the prior diagram before. And there is decrease in Th17 Treg ratio, and Th1 Th2 cytokine ratio also decreases. And this all happens through dendritic cells. These dendritic cells in the skin, they pick up these lymphocytes are injected intradermally, and they are presented to the mother's immune system, which then generates an immune response, which helps in protecting pregnancy subsequently, either at the time of implantation or during early first trimester. So that's how it works. Then how can you select, or how do you select a couple who will be benefited by this particular therapy? And we use certain investigations for it. There is a big list of investigations which is used in centers abroad, but for us, there are 4 specific investigations which we use. First is the lymphocyte cross-match. Second is the natural killer cells in the peripheral blood. Third is the serum TNF-alpha cytokine. Fourth is the endometrial natural killer cell estimation, and along with that, an infection profile. Now, what is this lymphocyte cross-match? It's a lymphocyte antibody detection test, and it measures the amount of antibody that reacts with the proteins of paternal lymphocytes. And a negative cross-match indicates that immunotherapy or lymphocyte LIT will be beneficial in a particular case. This is how the result looks like, and a strongly positive lymphocyte cross-match is an indication not to use lymphocyte immunization therapy, but otherwise in other cases, if it is when it is negative, lymphocyte immunization therapy is indicated and it will be beneficial. And it has been shown that the odds ratio of live birth was 4 times greater. The chances of success are 4 times greater in patients who are cross-match negative than the control groups in the success of LIT. The next is the estimation of NK cells in peripheral blood. This is a little complex investigation. It's done differently in different centers. We estimate CD3 and CD16 and 56 type of cells. And a particular pattern that we have seen in these patients is a high CD3 and low CD16 plus 56 is associated with RPL or RIF. The CD16 plus 56 are of 2 types, CD56 bright and 56 dim. The peripheral blood shows CD56 bright, while in the endometrium there are CD56 dim. We still don't have the test here in Abitas to distinguish these two, so we estimate the total CD6 plus 56. The meta-analysis of 22 studies done by Srividya Sheshadri and S.K. Sankara also confirmed that there is an increased peripheral NK cell number and percentage in repeated miscarriages. Endometrial NK cells, yes, this is a test which we use quite regularly, and to detect the endometrial NK cells, or to be specific, the CD57 type of cells. Endometrial biopsy is done in the luteal phase between 19th and 23rd day of the cycle. The endometrium is collected in formalin like we do for histopathology and sent for immunohistochemistry. And presence of CD57 cell indicates as an immunological problem, because CD57 cells are normally not present in the endometrium. It is the CD56 dim cells get converted into CD57 cells, and presence of CD57 cells is detrimental to pregnancy. Then the fourth test that we do is estimation of a cytokine called serum TNF alpha. TNF alpha is an inflammatory cytokine produced by NK cells, and it is raised in many inflammatory conditions like rheumatoid arthritis, where the levels are in thousands. But a natural level of 4 to 12, if it is breached, that if a higher level of 30, 40, 50, 100, it's detrimental to pregnancy. And what it does is TNF alpha, high levels of TNF alpha affect the vasculature, and they induce what is known as cytokine-induced vascular amputation, and because of which there are microthrombi and the blood perfusion circulation suffers, leading to miscarriage. And it has been shown that women who have repeated miscarriages, they have an unusually high level of TNF alpha because it inhibits formation of placenta, and it has problems in implantation. So that's how you select the couple. What is the procedure? The procedure, a lymphocyte immunization therapy is a daycare procedure. The couple has to be there in the center for 3 to 4 hours. The way we do it at our center is a single sitting procedure. There are centers abroad who have multiple sittings, 2 sittings or 4 sittings or 6 sittings, but that depends on what concentration of lymphocytes we use. The process we use is our own patented process, where we use a particular way of separating lymphocytes and a particular concentration so that a single sitting is possible. The procedure involves essentially collection of blood from husband. The cells are separated immediately through a process in the lab, and once the cells are separated, they are injected intradermally into wife as multiple intradermal injections. All precautions for the possible allergic reaction are taken when the procedure is being done. As a follow-up, the prerequisites that LIT requires is prior immunological testing, as I said, prior infection profile to prevent any transmission of infection, blood groups to know whether if the wife is Rh negative and husband is positive, then to use full dose anti-D. Then the couple is advised to plan pregnancy 4 to 6 weeks after the therapy, preferably within 1 year, but within up to 18 months. A booster dose can be given during first trimester, and there is a specific mention now of LIT in pregnancy, and there are now studies which have shown that lymphocyte therapy given in early pregnancy definitely increases the chances of success of pregnancy, and we have been doing this, using this, especially when the patient comes, presents with pregnancy with already history of multiple miscarriages. So that's what it's done, how the procedure is done. Is this procedure safe? Very important question asked by us, by our doctor friends, our patients. And we have been, as I said, associated with more than 1,000 LITs so far, and we haven't encountered any major side effects. No, only minor local allergic reactions, occasionally mild malaise, no serious allergic reactions like anaphylaxis, no long-term graft versus host disease or autoimmune problems. In fact, there is a big study by Kling from Germany in 2005 in human reproduction of 4,500 cases, and that has reported that there is no specific risk of our anaphylaxis, autoimmune disease, or graft versus host disease reported in those many cases. So it is so good, the safety is good, but it is not without controversies. And for that, we'll have to go back to 1999 for the REMIS study, or also known as the OBER study. This was a large trial which came out in US in 1999 and which was published in Lancet, and which recommended that LIT is not useful in preventing miscarriages in patients with repeated miscarriages. In fact, the study showed that the control group had 65% success, while the treated patients had 46% success, and therefore it recommended against LIT. In fact, there was higher rate of miscarriage in the treated group, but this study had a lot of flaws. This is the only study that it faced a lot of criticism. This is the only study till date who has shown a negative effect of LIT on the rate of live births. The biggest problem was the lymphocytes were prepared from blood which was stored overnight. And that was the biggest problem, because it was proved later on by Professor David Clark that for immunomodulatory effect of lymphocytes, the surface CD200 marker is most important. And this CD200 marker gets destroyed when the blood is stored. So the blood which was used, cells which were used in REMIS study had no immunomodulatory effect. So there was no result also. Also, it was discontinued for reaching the expected number. It did not exclude patients with autoimmune problem. With positive ANA test, patients were not excluded from this trial. And you just now heard, ANA is an important factor of a titer of more than 1 in 160 is a significant thing, well, but which was not considered in this trial, and therefore there were adverse outcomes. And there were many other problems like lack of post-immunization control, and the lymphocyte concentration was not fixed, the dosage was not fixed. But the subsequent Cochrane reviews, which came in 2003, 2006, 2014, were recommended against the use of paternal cell immunization, as there is no significant beneficial effect over placebo. And all these reviews, which were of 12 studies which were analyzed, and the maximum weightage was to Ober study. And this diagram shows an odds ratio of 1.22, where the Ober study had the weightage of 34%. But there were a lot of flaws in the Cochrane review itself, as shared by Dr. Christiansen from Denmark, who was here for the inauguration of our center, that the studies considered in Cochrane review did not consider whether the miscarriages were primary or secondary. There were number of miscarriages, the immunization dose, the routes of administration, all these factors which affect the outcome were not considered in the studies that were taken in Cochrane review, and therefore the Cochrane review itself was flawed. So therefore, a newer meta-analysis was done without Ober study, and it increased the odds ratio, showed odds ratio of 1.6, better than the previous one. But the most interesting part is in the current meta-analysis. There are certain newer recent meta-analysis. One in 2016 by Liu, he showed a 78% success rate compared to 46 in control. When the Ober study was not used, but he analyzed 18 studies, which included even the studies of the Cochrane review, and the success rate, the odds ratio was 4, so which definitely proved the efficacy of lymphocyte immunization therapy in 2016. But he did not include Ober study. So in 2017, a further new meta-analysis came up by MB Cavalcante, and here he included even the Ober study, and still there is significant improvement in the live births in patients treated by LIT with odds ratio of 3.1, which proved the efficacy of LIT beyond doubt in 2017. So these two studies, what they showed was, these studies concluded that LIT is a safe treatment. It stated that LIT is a valid treatment for couples when performed with lymphocytes which are fresh. It is beneficial when given before and during pregnancy. The best results were seen when LIT is done with adequate number of lymphocytes, and LIT is the most effective when applied intradermally, and LIT is beneficial in well-selected couples. Very important, the subgroups which will be benefited by LIT. So that was about the controversies. So is it really efficacious? So I would like to go to the last part with some of the studies. I went through literature for last 23 years, and there are close to 30 studies related to use of lymphocyte immunization therapy in RPL and RIF. I divided into 3 groups. 1997 to 2005, there were 10 studies. In 2006 to 15, there were 8 studies. And in the last 3 years, 3 to 4 years, there were 12 studies, which majority of them indicated that LIT is beneficial in RPL or RIF. So we'll have to wait for maybe next Cochrane review for some change. Cochrane review is known to change the opinions, especially with progesterone, you will agree with me. So it's not possible to discuss all these studies, but a few studies, a couple of studies I will share with you. One is from Dr. Manoj Pandey, our own from Lucknow, currently he's in US. And this study, which was published in Journal of International Immunopharmacology, where 124 women with recurrent spontaneous abortions were given lymphocyte immunization therapy, and the results showed 84% success rate compared to the other groups, where the next diagram shows that the paternal lymphocytes showed 84% success rate compared to either autologous lymphocytes or normal saline or no treatment, which proved the efficacy of LIT. The second study was by Liu in 2017, where the effectiveness of immunotherapy with low-dose lymphocytes in patients with unexplained RPL and with Th1, Th2, Treg paradigm disorders was studied. And the outcome was the proportion of Th1 cells significantly decreased after LIT. Proportions of Th2 and Treg cells significantly increased after LIT. And as you know that If there is increase in Treg cells or Th2 cells, this has a protective effect on pregnancy. The miscarriage rate was significantly less, to close to 11%, while compared to almost 35% in the non-treated group. So it concluded that the low dose LIT is beneficial in restoring Th1, Th2, Treg paradigm, and it improves the pregnancy outcome. And the last study I would like to share with you, very interesting and very well conducted study in a Journal of Obstetric Gynecology, Reproductive Biology, where more than 1,000 patients with RPL were taken into the study, those who had negative lymphocyte cross match. And they were divided into 4 categories. One was with only alloimmune problem, that is negative cross match. The second was with alloimmune and thrombophilia. Third was with alloimmune with autoimmune. And the fourth category was alloimmune, thrombophilia, and autoimmune. So you will agree with me, because problems are never isolated, they exist together. And what they did was each category was divided into 2 subgroups. And one subgroup was given LIT and the other was not given LIT. The associated conditions were treated to remove the bias. And the result that they got was the success rate in the LIT subgroup of each category were almost double than those with non-LIT group, which again proved the efficacy of LIT by taking care of other associated conditions. So this study, what it showed, that a careful laboratory test may identify subgroups of recurrent miscarriage patients most likely to be benefited by LIT, and it will exclude those who are not likely to be benefited. And the other observation they made was LIT during pregnancy will significantly improve the success rate. So friends, before ending, I would like to share a brief thing about evidence-based medicine, because it is, you will agree with me that for any subject or any topic that we in our practice, there are various studies, various trials, various reviews. But when we go to evidence-based medicine, it is very, you will agree with me that the physicians who follow the RCT-based guidelines in 100% of their patients will definitely have better results than those who don't follow at all. But the best results are seen with those physicians who are well informed and also who combine their own clinical experience with up-to-date scientific evidence, and their success is the maximum. The evidence-based medicine should also have active participation of the patients in the decision making, and they should make their values and preferences known. As Dr. Rishma said in the beginning of this, is about the evidence-based medicine and the treatment that we are giving. It should cause, the first principle is, first we should cause no harm. So like together the patient and physician can determine an appropriate course of action or no course of action, and if that is the joint decision. So that's what is the gist of evidence-based medicine. So whatever we discussed today should be looked through this light of evidence-based medicine and through whatever I have said. And I'm sure with this short take-home message, we will be able to help our patients to achieve their dream of having their own baby. In recurrent miscarriages and recurrent implantation failures, rule out all known causes. Consider alloimmune rejection as a possible cause. It's not for all, but there is definite some percentage of patients in this unexplained group who will require this. Do immunological tests, do immunomodulation treatment, active immunomodulation with lymphocyte immunization therapy, plan pregnancy within 1 year of LIT preferably, and use other immunomodulatory treatments during pregnancy, and this will definitely help these couples to overcome their problem and will reduce our frustrations in treating these patients. Thank you very much.
Thank you, sir, for such a nice and elaborate talk. Repeated implantation failure is a nightmare for patients and even IVF centers. Immunomodulation plays an important role, and lead therapy is promising new hope for RIF patients. Thanks for such innovative talk, and we are going to definitely use in our practice. I have 2 questions. We are doing blood NK cells from so many laboratories. So where to send uterine NK cells sample? First question. And secondly, sometimes we do blood TNF cell report, and that comes very low positive, like 10 or 12. So what is the right treatment for such low TNF alpha blood levels?
If I am supposed to take questions, we can take questions right now. I will answer. The first question is about endometrial NK cells. I think it is done very commonly by Metropolis lab, and it's an immunohistochemistry. I think any lab which does immunohistochemistry should be able to do the endometrial NK cell CD57 estimation. So that should not, it's a very simple test, and I think cost close to maybe 1800 or 2000 rupees. And regarding the TNF alpha, yes, if the TNF alpha levels are low, the normal range is 4 to 12 picogram per ml. If they are low, there is nothing is to be done. If they are high, then there is a way to treat. Before these patients plan pregnancy, the TNF alpha level should come back to normal. So there is use of antioxidants is recommended. Use of anti-inflammatory medicines like hydroxychloroquine is recommended, and very high TNF alpha, where anti-TNF alpha medications, the specific anti-TNF alpha medications like Humira can be used in these patients, though these injections are used commonly by patients with rheumatoid arthritis, but a dose of 2 injections at 15 days interval can be used in these patients to bring back these levels to normal before planning IVF cycle. The only disadvantage is it leads to a lot of immunosuppression, and which can sometimes pose problem of other infections like tuberculosis, especially in our patients. So anti-inflammatory medications or antioxidants are helpful in patients who have high TNF. And of course, lymphocyte immunization therapy will act as a first step, followed by these anti-inflammatory medications.
Thank you so much, sir, for such a nice interaction. Over to Dr. Chaitanya Shambekar.
Thank you, sir. Thank you, sir, for the talk. Due to lack of time, we'll have all the questions at the end of the program. Moving on to the next talk, I would like to invite the chairperson, Dr. Shekhar Amale, sir. Can we have the CV? Sir is the president, Nasik OBGY Society. Sir was the vice president, Nasik OBGY Society 2016. He is the director, Sai Women's Specialty Hospital, and has over 18 years of experience in gynec endoscopy. I would request Dr. Shekhar Amale, sir, to invite our next speaker. Over to you, sir.
Thank you, Ameya, for that nice introduction. Introducing Chaitanya is always a pleasure. I am introducing him a second time. He has visited Nasik twice. Introducing and talking about each and every achievement of Chaitanya. There are so many achievements he has achieved. If I skip up them, it will take 1 or 2 minutes. But to achieve all these things, he might have won so many years. So I would like the salient thing about Chaitanya. Chaitanya is a pelviscopic surgeon. He has earned his diploma in pelviscopic surgery in Germany. He is a past president of Nagpur OBGY Society. He is a chairman Infertility Committee Amogs. He is the executive member of ISAR. Then he is a member of Endocrinology and Endoscopy Committee FOXY. He is the recipient of Kamini Rao Yuva FOXY Oration Award and many more to him. I would like to be thankful to Amogs and the organizing committee for organizing such a wonderful webinar on the topics which are rarely spoken or rarely heard in the conferences. I must congratulate for choosing such nice topics, and I'm especially very thankful and delighted to be to chair a session which is going to discuss about histoscopy. That is my domain. Histoscopy in thin refractory endometrium. Something some people will finish off this in say 1 or 2 minutes, and we are going to hear from Chaitanya for say 10-15 minutes. So we are very much eager to hear from Chaitanya on this different topic and rare topic. Over to you, Chaitanya.
Thank you, Shekhar. I'll start screen sharing now. Okay, will you please stop screen sharing, Varsha? Yeah, thank you. So thank you, Shekhar, for such a nice introduction. And the topic is yes, interesting and something which we all can do in our day-to-day practice. That is the management of refractory thin endometrium and the role of hysteroscopy. So I welcome you all on this platform from Amogs, Nagpur Gynec Society and directors of Omega Hospital. इस हंसी शाम में आपका स्वागत है. I did this laparoscopic ectopic surgery 2 days back, and it was actually a 11 weeks embryo. And when you do such scopies, you start thinking that does embryo need endometrium for implantation? And the answer is yes. We need good endometrium for implantation. In fact, you should think different. ये एक्टोपिक क्यों हुआ? क्योंकि एम्ब्रियो को एंडोमेट्रियम से ट्यूबल म्यूकोजा अच्छा लगा. So endometrium was not so good, and so embryo tried to get implanted in the tubal mucosa, which embryo thought is better than endometrium. So you need good endometrium for implantation. Now sometimes only good endometrium is not so good, because if embryo is like a spoiled bad boy and endometrium is too good, the embryo will implant but it will abort. So here comes the role of philosophy of life. You should learn to say no. And if endometrium learns to say no to a bad embryo, then you will not be in trouble. But this is something which happens many times, that you get a very good endometrium but a bad embryo, and therefore you get abortions. So what you need is a good endometrium and good embryo, which is a win-win combination for all of us. With 99% transfer rates, the success rate of IVF is only 40 to 50%. And the most limiting factor is embryo implantation. Even top quality embryos, they fail to implant, and that's the bitter truth. So the focus is on endometrium, and we have to focus on endometrium today because that is the very important factor as far as implantation is concerned. And this is what we want: a very good endometrium with zone 3 or zone 4 vascularity, be it IVF, be it IUI, be it time intercourse, or be it natural cycle treatment. So everybody, all fertility specialists working here need good endometrium for implantation. And thin endometrium is actually a cause of recurrent abortions and also is a cause of infertility and recurrent implantation failures. So before discussing thin endometrium, I take this opportunity to discuss common characters between RPL and infertility. And I think this is a very important topic because both RPL and infertility, they are defined as a disease by ASRM, and the definitions of both the conditions are different. But there is an undefined border that brings them closer. Imagine a condition called as biochemical pregnancy, where the pregnancy test is positive, but there is neither an intrauterine pregnancy nor an ectopic pregnancy. After a few days, the beta HCG levels start falling and there is a termination of pregnancy. So you don't see the sac at all. So fertilization occurs, but implantation does not occur. So this is a spectrum where on one hand there is infertility, on the other hand there is RPL, and in between there is a biochemical pregnancy. When fertilization takes place, you call it recurrent pregnancy loss. When there is no pregnancy, you call it recurrent implantation failure. And as I said, this is a spectrum with many cases having common etiology. So what you need is a common clinic for the treatment of infertility as well as RPL. And if you just look at this diagram, you'll find that 90% of the causes or etiological factors of RPL and infertility are same. Only few specific causes like cervical insufficiency in RPL and maybe tubal block in infertility can be a specific cause, specific condition. Otherwise, almost all the conditions, they have common factors or common causes. And same is true with the investigations. If you start looking at the chart, you'll find that almost 90% of the investigations, they are common for RPL as well as infertility. For example, you take a case of say septate uterus, you need to do a 3D ultrasound, which is essential for RPL as well as for infertility. So that means it's a common thing. RPL and infertility is nothing but a spectrum. So what is the solution? The solution is that you should relate chemical pregnancy as a clinical pregnancy. That means chemical pregnancy is not in no man's land. It is a case of RPL. And this is something which you should all remember. And second thing is you should evaluate and treat RPL and consistent infertile patients in the same clinic under the same umbrella under a common platform. And this is important because unless you treat them under the same platform, you will not be able to treat them properly. Now comes the role of refractory endometrium. We all know that the definition is by and large endometrial thickness less than 7 millimeter means refractory endometrium. But the trends are changing. Initially, people thought that hypoechoic is better than isoechoic. Then people thought that 7 millimeter is the best endometrium. It should be always be more than 7 mm. But then there are few studies which say that even 5 mm or even 15 mm gives good results. Then came the role of Doppler and 3D volume ultrasound, where people started thinking that blood supply is more important. And now today is the era where we are thinking of molecular technology as a factor responsible for the endometrial receptivity. This is a paper by Velasco et al., where he has stressed the importance of various investigations and procedures to manage thin endometrium, where he has also discussed the role of hysteroscopy. And for all of us, the hysteroscopy is something which is important, and we are going to discuss this in the next 15 minutes or so. So it would be interesting to discuss hysteroscopic guided procedures in thin endometrium. And I think we can divide them into two procedures. One is hysteroscopy with endometrial scratch, which can be done more often even in IUI cycles, and hysteroscopic guided PRP injection, which can be tried in the patients of recurrent implantation failures. Now the question is, we know that the endometrium is a culprit in many cases. And the question is, can it be improved by scratch? And the answer is yes, it can be improved by endometrial scratching. It started by Barash et al., who in 2003 came to the conclusion that endometrial scratching helps in the implantation, and there is a twofold increase in the live birth rate with endometrial scratching. The procedure is very simple. You have to just, what you have to do is you have to do the intentional damage to the endometrium. You can use a PEPL. You can do this prior to endometrial scratching can be done before embryo transfer. You can do this before ovulation induction, or you can do this before IUI also. This is an office procedure which can be done just by putting a speculum. Or what you can do is you can do it along with hysteroscopy, because hysteroscopy is a procedure which can be done before starting any major treatment of infertility, and along with the hysteroscopy, endometrial scratching can be done. How the scratch helps? It helps by inducing the endometrial desodulation. It helps by inducing wound healing response, and also helps by increasing the number of NK cells within the endometrium. It is said that whenever you give any ovulation induction treatment, be it ovulation induction drugs like letrozole or HMG, the endometrium gets advanced, and this scratching helps in retarding the endometrial maturation, leading to better synchrony between the endometrium and transferred embryo, and therefore you get good results with endometrial scratching. So you need a Cochrane database of systematic reviews to confirm your finding. And here is a Cochrane database which says that they have a definite role to play as far as the thin endometrium is concerned. They have tried procedures, and there they have also discussed the role of PEPL versus hysteroscopy in endometrial scratching, and they have found that hysteroscopy also plays an important role along scratching. There are almost 18 studies which are RCTs which have been studied by this Cochrane database, and out of this two of the studies are Indian studies, and one is from Dr. Sachin Narvekar and Kamini Rao et al. It has been said that there is a moderate quality evidence which suggests that if 26% of the women achieve live birth without endometrial injury, then between 28 to 48% will achieve live birth rate with endometrial injury. So endometrial stretch is having a moderate quality evidence to help in implantation of the endometrium. But they have also said that you require additional well-designed trials. And here comes the role of various studies which came after this Cochrane database, which was published in 2015. And then came a scratch study, which is a 2017 study. This is a very large randomized control trial. This is a very interesting study because here they have tried to study not only the primary endpoint, that is live birth rate, but also tried to study the endometrial tissue parameters associated with implantation failures. They tried to find out what went wrong and what was the reason why the implantation did not take place. And this is the beauty of this scratch test or scratch study, that they tried to, in fact, they took the endometrium and they tried to evaluate the endometrium to find out the cause of implantation failure. But the sad part of the story is that I don't find any development in this scratch test since 2018. I did not find any development in this test, and this test final result is not yet available with us. Then there are many other studies which are there. This is interesting for all of us because Amox is a, it is a broad platform, so where everybody has logged in, so everybody would be interested in knowing whether scratching helps in IUI as well. And this is a study which says that scratch under USG guidance helps in improvement in of the success rate in IUI cycles also. What they did is they tried to do the scratching on day 6 of the IUI cycle. They called patient on day 6, and then they did scratching, and they found that the success rate improves with scratching in IUI cycles. Similarly, there is a Indian study which also says that IUI cycle scratching does play an important role. And an important paper is on the role of endometrial scratch in RPL, the topic which we are discussing today. And this is a RCT which has performed scratch in follicular phase prior to ovulation induction cycles. And they found that there is a reported reduction in the miscarriage rates in RPL patients when the scratching was done prior to ovulation induction. So there are a lot of studies which are available now. And of late, many studies are saying that scratch does not really help. And in 2020, there are 2-3 studies which have come up and which say that there is no use of doing scratch. But then you can see this study in human reproduction which says that everyone is doing it, and definitely there is no harm in doing it. And that is the reason why more and more people are trying to get the results with scratching. We tried this endometrial scratch along with hysteroscopy in all our IVF cycles, where hysteroscopy was done in all the patients 22 to 30 days before transfer. And out of 519 patients where we transferred in last 1 year, we found that without scratch, the success rate was 37%, and with scratch, it was almost 45%. In FET cycles, the success rate went up from 42% to 51%. So there is definitely a role of scratch to play. So to summarize, endometrial scratch improves the pregnancy rate. The scratch study is something which is coming up and which is definitely answer to many of our questions. And the beauty of this procedure is that it can be tried in IUI as well as natural cycles or inducted cycles, and everyone can do hysteroscopy along with scratch in their day-to-day clinical practice. I delivered this talk in AICOG last year, and after this talk, one of the senior gynecologists said that I started my practice in 70s, and that time we used to do DNC in infertility patients, and we used to get. So scratching is nothing but the same thing. It's a old wine in new bottle. Now, why do girls marry? Because you cannot blame government for everything and anything which is happening in your life. So you need husband, and endometrium is like husband. It is always there to bear the brunt. So we have to think of something more than scratching to treat the refractory thin endometrium. And here comes the role of PRP injection in cases of recurrent implantation failure and thin endometrium. Now we know that PRP is something which is going to help in regeneration of endometrium because it contains various growth factors like fibroblast growth factor, platelet-derived growth factors, VEGF, transforming growth factors, insulin-like growth factors, connective tissue growth factors, and interleukins. All these things, they help in regeneration of the endometrium. So we conducted a study at Omega where role of autologous PRP injection in refractory endometrium in patients with recurrent IVF failures was studied. PRP was injected in subendometrial layer on day 3 of menses of IVF cycle, either stimulated or FET cycles. And this was in contrast to most of the studies which studied the effect of intrauterine PRP instillation on the day of HCG of the IVF cycle. So what we did, we tried to inject the PRP in the subendometrial layer. The aim was to provide definitive treatment in patients of RIF, to improve endometrial thickness in thin endometrium in patients with IVF, and to improve embryo transfer outcomes in IVF patients. Study was conducted at Omega Hospital for a period of 1 year. Permission was taken from ethics committee, and 22 patients with RIF and known thin and refractory endometrium were selected and recruited for the study. And autologous PRP injection was injected on day 3 of menses of fresh or frozen IVF cycle. So all patients with 2 or more IVF failures were included in the study, and those with known refractory thin endometrium were included in the study. Patients with structural uterine anomalies and women who were not fit for conception were excluded from the study. We did PRP with this PRP kit, that is precursor PRP kit. This kit is available in the market, and I can give you the number and a video of this, how to make the PRP with this kit. It is very easy to do. You have to just open the PRP kit, and PRP kit has got a tube, and invert and mix it gently 5 to 6 times. Then put it into R8C centrifuge machine, which is centrifuge, at 3500 to 4000 RPM per minute for over the period of 10 minutes. You will get the 4 layers of the coats in the tube, where 2 ml of upper layer is platelet poor plasma, 2 ml of second layer is platelet rich plasma, third layer is of inert gel barrier, and a fourth layer is of RBCs. You have to aspirate first 2 ml, which is a platelet poor plasma, without shaking the tube, and then invert the tube and mix the contents. The last step is to aspirate the 2 ml of PRP, which is now the upper layer, and now the PRP is ready for use. Once the PRP is readily available and it is made available for use, you have to inject the PRP into the subendometrial lining. So how we do it? We use Bertocci 2.9 millimeter hysteroscope, which is a office hysteroscope with an operative channel, and a ovum pickup needle and a reprolin needle is used. This is a specific needle because you can attach the syringe directly to this needle. So in number reprolin needle is used. PRP 2 ml is syringe is attached to this reprolin needle. After attaching this PRP, what we do is we just inject the PRP with the help of Bertocci hysteroscope for injecting the PRP. And the PRP is injected into anterior and posterior wall of the uterus in the subendometrial lining. And this procedure is carried out under short G. Now you can see this video where you can see that this patient was, I have chosen this video because this case was a very classical case of thin endometrium, and the patient had amenorrhea, and this patient had PPH, and her baby died during PPH, and you can see the endometrium, and the Bakri balloon was used for control of bleeding in this patient. After this, she had amenorrhea and recurrent implantation failure. So we try to evaluate the cavity, and then we used this needle, that is reprolin needle, to inject PRP into the wall of the uterus, into the cavity of the uterus in the subendometrial lining. So as you can see, this is the cavity. So what we did is we just put the needle inside, and you can see the needle which will appear on the anterior wall, and with the help of this needle, the PRP was injected. Inject PRP in at 2 places, anterior wall and the posterior wall. As you can see here, again the needle is seen, and again it is injected in the posterior wall. So this is how the procedure is carried out. Now this procedure is technically very easy, and that is the biggest advantage of this procedure. It is very easy to do this procedure, and it does not need a great expertise. The results which we got 12 patients HCG positive out of 22 patients. So the result was more than 50%. And out of these, 2 had, there was no appearance of cardiac activity. So 10 out of 22, that is 45.45% women had clinical pregnancy with appearance of cardiac activity and ongoing pregnancy. So the incidence is not very high, but treating this patients with refractory endometrium is a big challenge for all of us. And we know that PRP acts by many ways. Endometrium contains receptors for all the growth factors present in PRP. It helps in endometrial proliferation, desetialization, and placental angiogenesis required for embryo implantation. Thus, we are exploring the specific effect of PRP on human endometrial regeneration. There are many studies This is a famous study by Chang et al. Where they tried to infuse PRP in 5 infertile women and they get 4 out of 5 pregnancy. That is the result. So almost 90%, 80% success rate they got. Here they infused PRP on the day of HCG injected. Similarly, this is by Molina and a study where 50% result was obtained in 5 out of 10 patients. They got pregnancy after infusion of PRP. Now you can see that most of the studies, there is no reference for PRP injection in the subendometrial lining, that is the uterine wall. All the studies are regarding PRP instillation or infusion inside the cavity, just like GCSF. So we tried to PRP instillation in a couple of cases initially. It was done on the day of HCG. However, we found that it did not work. In fact, it leads to collection in the cavity and disruption of the endometrial lining. So we decided to abandon this procedure. So infusion of PRP into the cavity was abandoned because the collection was actually disrupting the endometrial lining and there was no result. So in present study, we injected PRP in subendometrial lining. This was done on day 3 of menses. This gives adequate time for regeneration of the endometrium without disturbing the intrauterine milieu, and that is the advantage. So to conclude, a single sitting of autologous PRP injection into the subendometrium has increased endometrial thickness and improved the embryo implantation outcome. There is minimal risk of transmission of infectious diseases because it is a autologous blood sample. Endometrial microvasculature gets benefit of growth factors when it is injected on day 3 of the menses. Endometrial thickness is improved and PRP is safe, easy and cost-effective procedure. So the take-home message is refractory endometrium is difficult to treat. Hysteroscopy can be used as a mode or method to treat this problem. Endometrial scratch is an established treatment modality which can be used along with hysteroscopy, and hysteroscopic guided subendometrial PRP injection is a new modality with promising results. So ultimately, the philosophy of life, friends, is कर्मण्य वाधिका रस्ते मा फलेषु कदाचन कर्म करते रहो फल की आशा न करो, and same is the philosophy of treatment of RPL as well as RIF. Thank you very much. Thank you.
Okay. Sir, we come to the end of this session.
Thank you, Chaitanya
Thank
sir,
you
for
so much,
this
sir, for a wonderful
insight.
talk. Now
Thank
we
you.
proceed. Now we proceed to the next session, that is a panel discussion. For this, I would like to invite the chairpersons. Firstly, Dr. Nilima Thakre, ma'am. Ma'am is the president, Amravati OBGY Society. Ma'am was the treasurer, Amravati Amogs 2020. Ma'am is the recipient for the Shailaja Chaudhary Award 2019. Ma'am is the senior faculty for various OBGY conferences, CMEs and workshops. Next chairperson is Dr. Pandit Palaskar sir. Sir is a pioneer in the field of gynec endoscopy and assisted reproduction in India. Sir has performed over 50,000 surgeries in the field of gynec endoscopy. He and his team has treated many infertile couples, resulting in babies to more than 15,000 couples through various treatment modalities. Next is Dr. Kirti Sane ma'am. Ma'am is the President Chandrapur OBGY Society, former Vice President IMA Chandrapur. She is a senior practitioner and founder member of the Chandrapur Obstetric and Gynecological Society. Before we proceed, I would request Dr. Pandit Palaskar sir to kindly give an insight to this program and to RPL.
Hi, good evening, everybody. First of all, thank you so much for your kind words. I must congratulate Dr. Chaitanya Shembekar and team Amogs for organizing this wonderful webinar on RPL. Everybody know RPL is a very commonly encountered problem. Most of the times it is difficult to diagnose and treat, more difficult than diagnosis. So we have esteemed panelists to from all over the India to enrich our knowledge regarding the recurrent pregnancy loss. I am sure the moderators and panelists they will be doing a wonderful job and they will clear all our ideas regarding the diagnosis and management of the RPL. Over to you. Thank you.
Now I would request Dr. Nilima Thakur to invite our moderator, Dr. Parag Beniwale sir, to moderate the session. Over to you, ma'am.
Thank you. At the outset, I would like to thank the Amogs Infertility Committee and Dr. Chaitanya for involving us in this webinar and for giving me the chance to chair this session. As we are in the second part of this program, that is the panel discussion, Dr. Parag Biniwale will be the moderator. And as you all have learned from these three talks by the stalwarts that RPL is always many a times is an unexplained condition, and what comes to your rescue is the experience of your colleagues shared with you and the experiences shared by the stalwarts. So the topic of this panel is your experiences. And for that, we have none other than Dr. Parag Biniwale, who is very well known at this juncture as the Secretary of ICOG, who is helping all of us throughout to avail the credit hours. And he's so much helpful that you just call him or just put a message and the credit hours are yours. Thank you, sir, for that. Dr. Parag is the Senior Consultant OBGYN Gynec Pune. He is the Unit Head of and PG Teacher Kamla Nehru Hospital. He is the Secretary ICOG 2018-20, President Menopause Society Pune, National Joint Secretary IMS 2017-18, National Website Editor of Foxy 2011 to 2017. He is the peer reviewer of Journal of OBGYN of India 2012 to 17. He was the chairman Young Talent Promotion Committee, Foxy 2008 to 10. He is the master trainer for adolescent friendly health services, conducted workshops for WHO. He is the co-editor of Gynecological Manual on Adolescent Girl and Young Women. He has contributed many articles and books and journals. He has delivered a number of guest lectures at many conferences, and he has received the ICMCH award in the conference of in the same. Can I have the last line? It's not clear on my screen.
No, that's okay, Nilima.
Yeah, okay.
Thank you very much.
Over to Dr. Parag.
Can I share my screen, please? Yeah, thank you, Nilima. Thank you for those kind words. Good evening, all. I bring greetings from ICOG, the Indian College of OBGYN. And thank you, Chaitanya, for having me here. And thank you, Amogs, led by Nandita, for having me here to moderate a panel on RPL. All of us have been listening to the three presentations and how these difficult cases are being used. Now we are going to put it into practice and see how our experts are going to help us. And it's a pleasure to introduce the panelist. Is none other than Akshari Khande, who is the chairperson at ICG. She will be chairperson in the year 2022. Currently, she is national corresponding editor, Jogi, past senior vice president, Foxy, past president of Nagpur OBGYN Society. Pleasure to introduce Dr. Anahita Chauhan, who is an honorary consultant at Saifi and Elizabeth Hospital, Mumbai, former professor and unit head at the prestigious SET GS Medical College and KM Hospital, Mumbai. Currently, she is secretary of Mumbai OBGYN Society and second joint editor of Jogi. Next is Dr. Nali, immediate past president, to attend the Amogs 2021, which will be chaired by her. And she's a well-known endoscopic surgeon and infertility specialist. Next is Dr. Anjali Bhirod, who's director of Chandrama Hospital and Durga Test Tube Baby Center, Jalgaon. She's a former president of Jalgaon OBGYN Society, and under her presidentship, Jalgaon Society had won Best Amogs Society. Pleasure to introduce Dr. Kiran Sarda, who's director of Sarda Hospital, Solapur. Currently, she's president of Solapur OBGYN Society, and she's active in other organizations as well. And the next two are my favorite youngsters, Dr. Nilesh Balkode, and my objective is by which is not mentioned, is recently elected as chairperson of quiz committee of Oxy and one of the brightest POJs boys whom we have a lot of expectations, Shetkar, who's currently the second joint secretary of Amogs and probably one of the most enthusiastic boys we've all seen. Right, we are going to discuss certain aspects of RPL, and I'll just quickly introduce the topic. This is a condition all of us know where woman has 2 or more clinical pregnancy losses or miscarriages before the pregnancy reaches 20 weeks. This is as per the ASRM 2020. It also mentions that the losses are classified by pregnancy is healthcare provider use ultrasound, and chemical pregnancy is seen and discussed causes of repeated miscarriages, and the sad part is in 50% cases we are unable to pinpoint why there is a miscarriage. So straight away we'll go to the first case, and I'm going to ask this question to Lakshmi. Lakshmi, a young couple comes with a history of first spontaneous abortion of 7 weeks. She wants to consult for future pregnancy outcome. Now, the question that they ask is genetic testing required for the couple?
Parag, it will depend on the history, whether they are having the history of consanguineous marriage and what is the age of the mother as well as father. Because previously we used to say that only age of the mother matters because of the aneuploidy embryos. But now if the paternal age is also more than 40 years, it can also have an impact on the pregnancy outcome. As you have shown, it is the first trimester abortion, and we know that genetic causes are more common. And I really want to give a take-home message that history taking will form a broader perspective for a treating clinician, which investigations to offer, because even we have, I mean, n number, more than 100 evaluation tests which are available. But for this patient, if there is a history of consanguineous marriage, or if the mother's age is more than 30 and father's age is more than 40, I will definitely advise parental karyotyping in this couple.
Okay, Anahita, do you agree with what Lakshmi has said?
Thank you, Parag. I actually only agree on the point of consanguinity. Other factors, I would definitely not do a genetic counseling or a genetic testing if the mother's age was more than 30. Maybe if she was closer to 40 and this was a pregnancy which had been lost, I may consider it just to speed up the evaluation process. But at 30, I would definitely not want to do genetic testing after a single spontaneous abortion.
Right. So after a single spontaneous abortion, the evidence says that there is no need to do genetic testing. And as Lakshmi has said, we have to counsel and reassure the patient. And of course, there's a 95% chance that the pregnancy the future pregnancy might result in a good outcome. Okay, now the same couple comes back after some time. She is 9 weeks pregnant, and Nalini, she comes to you with all high-risk supportive management which you've started. You do an ultrasound, it suggests gut hernia or omphalocele. What to do next?
Actually, gut hernia or omphalocele, if it is present around 9 weeks, it is the physiological omphalocele, unless it is said that if the diameter is more than 7 millimeter, you have to look for the color Doppler and see whether it is the omphalocele only and not the gastroschiasis. Because right, in this case, in gastroschiasis, there will be the rent in the abdominal wall of the fetus, and all the intestines will be in the amniotic fluid. So you have to differentiate between the omphalocele and the gastroschiasis. But if omphalocele is there, then you have to wait till 12 weeks. Sometimes physiological omphalocele will get regressed, and at 12 weeks, if it is there, and if there are other signs of chromosomal abnormalities, that is the NT scan is on the higher side, then in that case, tell the patient that this pregnancy will be abnormal one.
Right. So for this stage of pregnancy, as Nalini has very rightly pointed out, gut hernia is physiological. So we must call it at least at 11 weeks for NTs, high risk for fetal aneuploidies. And as Nalini has said, prenatal genetic testing is very, very important in this case. I would pose this question to Anjali next. Anjali, a 28-year-old third gravida who has had 2 previous miscarriages at 9 to 10 weeks. No investigations have been done. Now she's into her third pregnancy. She comes to you at around 12 weeks with cystic hygroma, and she wants to consult for pregnancy outcome. How are you going to counsel her and how are you going to manage her?
First of all, I will ask her whether she has got consanguineous marriage, and previously she has been done the products of conception for the karyotyping, and whether the report of previous products of conception. And now she is having cystic hygroma. So I have to counsel her about the present situations and do the karyotyping of the present pregnancy.
Okay, fine. So Kiran, now she wants to terminate this pregnancy after we have counseled her that the outcome may not be proper. There is a genetic evaluation. How should we proceed? Should we do a CVS or should we send the abortus material for examination?
At the outset, I thank you, Amogs and all organizers, Dr. Chaitanya, Dr. Parag, for involving us in this wonderful webinar. Now, we will come to the case. We know that this is the case of cystic hygroma. Cystic hygroma means the blockage in the lymphatic system, usually found in the in front of neck. Now, we have noticed that this is cystic hygroma, and if it can be hereditary or acquired. If we are knowing that we have to terminate the pregnancy, we should not directly jump to terminate the pregnancy at any region, because this cystic hygromas start developing in the early second trimester, means up to 9 to 16 weeks they can grow, and many of the times they spontaneously regress up to 20 weeks. But
12 weeks.
Here
She's 12 weeks and now we have diagnosed her to have cystic hygroma.
Yeah.
So what to do next?
Exactly.
CVS
We have
or
to CVS,
terminate the pregnancy, send the abortus for examination?
Definitely we have to do CVS first, because at 12 weeks we can do chorionic villus sampling, and we should see whether if it is not in favor of ours, means aneuploidy or like that is there, then we have to terminate, but we should do CVS first.
Okay, Nilesh, now the question this lady is going to ask you is, anyway, I'm not willing to continue this pregnancy, so why not to send abortus material for further evaluation?
I think if we are going to abort, we can say send the abortus material for microarray CGH, which will be a more specific test to diagnose the chromosomal abnormalities. And she had a past history of 2 abortions. So I think this genetic testing is must. And if she's going for abortion, then definitely products of conception would be the preferred method, and microarray CGH will be the preferred method.
All right. So what the literature recommends is, ideally, and if the patient is willing, we should opt for chorion villus sampling, because the report is going to be accurate. It will be done under sterile conditions, so no chance of contamination and wrong reporting. And it helps deciding the evaluation and outcome of future pregnancies. Just to summarize, the genetic causes affect 1 to 3% of women. The first trimester loss is seen in about 75%. 90% are anembryonic or blighted ova. We must investigate the patient properly. Chromosomes of fetus parents are to be examined as per the case. Advanced maternal age is one factor which we have to remember. And of course, we also have to keep single gene disorders in mind. And the diagnosis is done by the karyotype of abortus, fetus and placenta. Parental karyotypes can be certainly be done. Of course, genetic counseling is a thing that has to be done before we subject the parents for karyotyping. Culture methods of tissue cultures are expensive, laborious, subjected to external and maternal cell contamination, and there's no justification for routine testing of products of conception. Right, we move to the third case, and Ron, this is for you. A third gravida with previous 2 spontaneous miscarriages around 7 weeks. The transvaginal scan shows this. Ron?
Hello.
So what is the diagnosis and how are we going to go further?
So if you're looking at it, it could possibly be it's showing at adnexa. If you see it, the adnexa is showing a hydrosalpinx with the tubo-ovarian pathology.
Right.
So it could be an ectopic pregnancy as well. Per se, we would want to start doing her. So at how many weeks? I'm sorry, my internet's a little this, so I couldn't see the previous slide.
Oh.
So she's at 7 weeks.
She's not, yeah. See, she has come to you with this. She has history of 2 miscarriages. Right now she has missed a period, but then she has come to you with her TO mass.
Can I take this up, Parag?
Yeah.
I think Rohan's internet
Rohan
connection is lost.
Facing challenges. Your mom was also facing challenges with the internet.
So I think, sir, this is a tubo-ovarian mass with a history of prior to losses. We have to think highly of the possibility of tuberculosis and a thin endometrium probably, which has led to the loss.
Right.
Agreed.
Okay. Nalini, what is the relevance of genital tuberculosis in RPL?
Genital tuberculosis will affect the endometrium. In that case, the endometrium will not be mature enough to hold that pregnancy. Because of that, also there is increased chances of RPL miscarriages,
Right.
recurrent miscarriages. So, in order to avoid, you have to see whether there is a tuberculosis. So it is one of the tests to diagnose the causes of RPL.
Right. Lakshmi, how will we go ahead in such a patient? If you are suspecting genital tuberculosis, if the picture is seen like this, where you are suspecting some amount of adhesions, how are we going to go further?
Yeah, hysteroscopy provides you the see and treat approach in the same sitting. So we have to send, if at all we could lay our hands on the material, we have to send it for TB culture. And in the same sitting, you have to tackle the synecdoche as well.
Right. So tuberculosis, all of us will agree that if treated gives satisfying results.
Yes.
Okay, so now many microorganisms are found in genitourinary tract, pathogenic or opportunistic. So should the couple attempt to conceive in such a patient? Kiran?
Yes, before conception, we should take a chance to clear the infection as far as possible, and we should give the appropriate antibiotics and prepare the endometrium also. When later, we can ask her to take the chance. That is better to advise.
Right. So it's always prudent to investigate, find out what is the infective organism, and then treat it as per
accordingly.
The sensitivity. Yeah. Anahita, your take on torch testing in RPL. There was a time we used to, order torch for each and every case of RPL, maybe a 6-week recurrent miscarriages.
I don't think I have done torch testing in any case, RPL or otherwise, unless in a current pregnancy, I'm finding something abnormal. And I think your slide says it all. We should bury and say goodbye to the torch test, because torch is never a cause of recurrent abortions. It may be the cause of a single spontaneous abortion. And I think this fact, every single conference, we are saying the same thing again and again. And still I have patients coming to me saying, my IgG is positive, what do I do? And, I think the understanding is lacking when patients
keep on having to do the torch test again and again. So I can't
Absolutely.
overemphasize that in an ongoing pregnancy, if we are seeing something abnormal with the fetus, we are seeing a symmetrical growth restriction, or we are seeing something else, you may want to consider doing a part of the torch panel. But otherwise, for RPL, you should not be doing it.
Absolutely. And in fact, when we talk about torch, the fetal medicine specialists would vouch that they would do amniocentesis and do a torch PCR. So that is what they would recommend rather than doing a torch, because this is still happening. About 2 months ago, I did come across a patient who had a miscarriage of about 6 weeks, and it was an embryonic pregnancy of 6 weeks. We got everything done, and she went to somebody for a second opinion, and she was advised torch. And this was in the city of Pune by a young gynecologist who probably should know these things better.
And definitely
And as far as infections are concerned, Nilesh, I think absolutely. So Nilesh, can you just elaborate on infection in both partners?
I think sexually transmitted infections, especially we should think about chronic endometritis in some of the cause as an important cause of both unexplained infertility. For IVF, we have cases of RIF, recurrent implantation failure, and also cases of RPL, recurrent pregnancy loss, where we should think about chronic endometritis. We have hysteroscopy as a diagnostic module for these patients. Will we see the triad of stromal edema, strawberry appearance, and micropolyps on hysteroscopy. And along with this, we can send the immunohistochemistry of the endometrium in the form of CD138 for these patients to rule out any presence of infections. I think other infections of the accessory glands, as you have mentioned, that E. coli, Staph aureus, any of the accessory glands in the male and female can be a cause of RPL, and this should be ruled out.
Okay.
Parag, can I add that torch? Parag?
Hello?
Yeah.
Bacterial vaginosis also new things they are saying that they can also cause the recurrent pregnancy loss.
Absolutely. Absolutely. You are very right, Anjali. Yes,
Parag?
Lakshmi?
Parag, torch, I just want to give another take-home
Lakshmi, you
message.
wanted to add something?
Yes. What
Yes.
Anahita said is absolutely correct. I just want to give one more take-home message to our own colleagues. Whenever they are advising torch, IgG and M, the moment they see IgG positive, they just jump to the treatment, torch needle and whatnot, and they tell them patients not to conceive till it becomes negative. So I want to pass on the message that sometimes IgG remains positive for their whole life. So whenever you are ordering any test, you should know how to interpret and what influence it is having on the patient's management.
True.
Contrary, we should make it clear that IgG means they are getting immunity and not the infection.
Yes.
True. Okay. We move to the fourth case, and she's a third gravida, two spontaneous miscarriages, which were around 15 to 16 weeks. Now she's 14 weeks pregnant. She gives typical history of quick, painless, causeless abortions. She's not been investigated before. The ultrasound shows funneling of internal loss. Anjali, what is the importance of cervical length and funneling?
It is a case of cervical incompetence, which we cannot diagnose. It is only on history we can suspect. If the cervical length is less than 2.5 centimeter before 32 weeks, 28 weeks, then you can diagnose as a cervical incompetence. But
yes. Right. So it is prudent that we keep monitoring cervical length and the funneling. And here we have to understand that the cervical status has to be evaluated by a transvaginal ultrasound, a transabdominal ultrasound. The values of the cervical length given by transabdominal ultrasound may not be accurate because it will entirely depend on the fullness of bladder. Okay, Nalini, what is the role of urine culture or vaginal culture for this patient?
In this patient, urine culture is necessary because repeated urinary tract infection will also cause the Yeah, as well as the bacterial vaginosis will also cause the recurrent pregnancy losses. So in order to avoid those infections, we have to do the urine analysis, culture and sensitivity, as well as the vaginal cultures can be taken in these patients. Before cerclage, it is mandatory to see that the per vaginally infection is not there.
Right. Yeah, so it is extremely important that we keep this thing in mind and order for urine culture sensitivity and vaginal cultures if required. And women who have history of 3 or more second trimester termination losses in whom no specific cause other than potential cervical insufficiency is identified should be offered elective cerclage at 12 to 14 weeks of gestation. And
can I?
Yeah, sure, Ron.
Sorry, sir, my internet's a little bad, so I keep on logging off and on. So even though the SOGC criteria does say 3 or more losses, I think even if we have 2 or more losses, it should be offered to the patient because it's in terms of their emotional and physical stretch which they're going through. At the end of 2 losses, I think I think we as gynecologists should end up offering it to them and not wait for a third loss to occur, sir.
One more point.
Absolutely. So, Rohan, it has to be case dependent. Yeah. Nilesh, yes.
Yes, sir. So I think if in a case we have a failure of McDonald's cervical cerclage, we should also think on other routes of doing the cervical cerclage, other techniques in the form of Shirodkar's or modified Shirodkar's technique or a laparoscopic cerclage or an interval cerclage for such kind of patients.
Okay. Nilesh, can you just elaborate a little bit about laparoscopic cerclage?
Can I say something, Parag?
Yeah, Anaita.
So I think all these situations
Yes, Anaita.
which Nilesh is talking about are extremely rare. So the message that we should be giving to the audience is that after 2 or after 3 losses because of incompetence, she requires a cerclage. There will be a very rare case where you will have to do an internal or a laparoscopic cerclage.
Yeah, ma'am. I am talking about the conditions like the category of patients coming to me for IVF. They had maybe losses or maybe a very high risk pregnancies. In this patient, already cerclage was put, and we have around few patients where McDonald's has failed. So my view was that everybody should know that there is an alternative of abdominal cerclage or an interval cerclage in such kind of patients. Nothing more than that. Yeah.
Yeah, I also know there are failure of 2 or 3 McDonald's procedure, and we have in Solapur also some endoscopic surgeons who are doing laparoscopic encerclage, and it is successful also. So we should know the modality.
Right.
Yes, if I interrupt, Parag.
Sure. Tell me, Chetan.
Yeah, we are doing laparoscopic encerclage. I have done 4 cases in last 2 years. So we don't do it frequently. But as Nilesh said, some patients are so typical that they have, in spite of encerclage, they tend to abort.
Right. So
So
Chaitanya,
these
are
are
you
the
doing
situations
it as
where
an interval
laparoscopic encerclage helps.
during
Interval
pregnancy or
laparoscopic
in a
encerclage.
non-pregnant
No,
stage?
in a non-pregnant.
Non-pregnant
It is
stage.
preferable to do an interval
non-pregnancy.
cerclage than a pregnant laparoscopic cerclage because pregnancy it is technically difficult, and interval laparoscopic cerclage is a very easy procedure. Just with the dissection of the bladder fold and putting a Marcelin tape from
we
the
use
posterior to the anterior aspect, and then reclosing the UV fold would help and serve the purpose.
Right.
Anaita, what is the role of cervical cerclage in multiple gestations? Again, there was a time when we used to recommend the cerclage to each and every multiple gestation woman.
Would think that except for really, IVF or some other very high risk condition, I do not routinely recommend cerclage for multiple gestations.
Even for IVF pregnancies, we don't recommend a routine cerclage for twin gestations, even if she is IVF pregnancy.
I don't recommend.
We don't recommend the cerclage.
So
I think
absolutely.
Yes, all indications which are for singleton pregnancy should be for twins pregnancy.
Right to twins,
Even if it's a multiple gestation or through IVF, it's important that we keep looking at the cervical length, and only if the cervical length is short or there's any then only should we be offering cerclage to them at that point, not as a
Right.
routine
And then
just
it
because
has
it's
to
an
be
IVF twin gestation.
right. So it has to be case to case basis because the data does not support the use of elective cerclage in multiple gestations, even when there is a history of preterm birth. So the SOGC says that it should be, in fact, avoided. Right, we move to the fifth case, and Nalini, you can take this case. A 30-year-old who has had 3 miscarriages, 18 to 20 weeks. You do a pervaginal examination, you find out that it's a small uterus deviated to one side, and this is the HSG picture. How will you proceed? I'll just show you a better picture. Yeah.
So it is a case of unicornuate uterus, but sometimes by septate uterus might present like that only. Because of the septum, you cannot see the another cavity or bicornuate uterus, another horn of the bicornuate uterus you cannot see. So in these cases, you have to have the laparoscopy or hysteroscopy. If the septum is there, then the septum is to be removed. But in case of urinary tract in case of unicornuate uterus, it is and there are high chances of cervical incompetence. So or straightening or cervical encerclage is must in these cases.
Okay. Now, what the literature is saying that there is evidence that suggests expectant management and cervical cerclage has to be USG indicated. Rohan, what investigations can be offered to rule out anatomical factors in RPL?
So if we're looking at anatomical factors, our main thing is what we're looking at is a cervical length is one of the main factors is what we would be looking at in a patient of RPL. So at the time of pregnancy, if you're looking at prior to pregnancy, obviously, sir, my most
Rohan, here we are looking at talking about the uterine anomalies.
Okay, sir. If we're talking about anomalies, sir, I generally either prefer a 3D USG or a hysteroscopy, which would give me a see and treat option. But one thing, sir, we need to understand is most of the times if we see a septate uterus, it's sometimes advisable to consider using a laparoscopy as a backup as well, because it could be a bicornuate uterus, which could be just misdiagnosed as well. So at times when we are, if a USG, because generally our first investigation is a simple USG, which we do, which may show a query bicornuate or query septate uterus, which most of the radiologists can report it as. So it's important that firstly you do your own USG, and if possible do a 3D USG, which would give a much better picture in that sense. And if it is a septate uterus, then a hysteroscopy would really be beneficial for these patients. I don't do too many this sonohystographies myself, so I'm more of an opinion of either 3D USG or a hysteroscopy alone.
I would like to add here, sir.
Absolutely. And Nilesh, I'm going to ask you the next question anyway. So what treatment can be offered to patients with anatomical factors in RPL?
Okay. So basically, we should understand that anatomical factors can be divided into 3 aspects. First is the genetic part or the Mullerian abnormalities in the form of septate uterus, unicornuate uterus, bicornuate uterus, and so on. Then we have the acquired anatomical abnormalities in the form of fibroids, adenomyosis, which are external, and we have the acquired internal, which is the internal causes, intracavitary causes in the form of polyps or submucous myomas. So treatment will be lined up accordingly. So surgical intervention is especially useful in septate uterus. For unicornuate and bicornuate uterus, a metroplasty procedure is not advised as per literature, and we should not venture into this. Septate uterus, yes, definitely should be treated. If there is a history of cervical incompetence, that should be treated. For all submucous myomas or submucous fibroids, we should offer a treatment before the patient goes for the next pregnancy. However, fibroids which are away from the cavity, which are type 3, type 4 and not indenting the cavity, these may not be offered. Cases of severe adenomyosis also you need to treat before the patient goes into a pregnancy later on, because these patients are known to abort at around 8 to 12 weeks if the adenomyosis is severe. So we should treat these patients also.
All right. And we also have to keep in mind that many a times abnormalities like unicornuate uterus are associated with endometriosis. So we have to be really vigilant about it. Okay, Lakshmi, what is the role of progesterone in recurrent pregnancy loss?
Again, the literature is divided, but we do give progesterone to all our cases of recurrent pregnancy loss. And here it is said that dydrogesterone has a role of immunomodulation. So it is preferred over natural micronized progesterone. But yes, we should supplement luteal phase in these cases of RPL.
Okay. Any other opinion about progesterone, especially in the first trimester? Anjali, do you want to add something to what Dr. Lakshmi has said?
I'm agree with her. Only thing we have to start it from the luteal phase itself, means after, before the diagnosis of pregnancy. So it's better to give it. And I'm prone for the giving progesterone.
Yes.
So I think
everyone gives.
Yeah, yeah.
Everyone gives progesterone.
Yeah. Nilesh, you wanted to add something?
Yeah, the duration of where the progesterone should be used, as Anjali madam has rightly said and Lakshmi madam, that we should start it in the luteal phase as well whenever we are thinking of RPL, and we should not stop till around the placental function takes over. So till around 8 to 10 weeks of pregnancy, it is must. So the first trimester should be covered.
Very true.
Yeah.
And
We give up
for
to 12 weeks.
yeah, and for those patients who have landed up in late second trimester and early third trimester losses, the preferred molecule is hydroxyprogesterone acetate. So for these patients, a different molecule has to be used.
Yeah, synthetic progestogens.
Absolutely. So vaginal progesterone and natural progesterone, however, did not affect the miscarriage rate. However, intramuscular 17-alpha hydroxyprogesterone caproate and oral dydrogesterone were both associated with a significant risk reduction in miscarriage rate. Of course, if you are looking at prevention of preterm birth, micronized progesterone definitely scores. Yes. So does 17-alpha hydroxyprogesterone caproate. Okay, Nalini, what is the value of screening for metabolic or endocrinological abnormalities in the diagnosis of RPL, and which test will you advise?
The metabolic abnormalities or endocrinological abnormalities are diabetes or hormonal tests such as thyroid, hypothyroidism or hyperthyroidism also cause RPL. Then the hyperprolactinemia also increase the risk of RPL. Then the PCOD cases wherein LH is high level and the androgens are increased. In that case also RPL will increase. Homocysteine levels are to be also to be measured, because hyperhomocysteinemia will also induce the recurrent pregnancy loss. So the investigations recommended are thyroid, that is TSH, TPO antibody, T4, and but other tests are blood sugar level, and it is said that it is not recommended, but a few tests such as prolactin can be done.
Just want to add, Parag. Hello.
Yes, go on.
Yes,
only the uncontrolled diabetes mellitus is responsible for adverse pregnancy outcome. If the diabetes mellitus is well controlled, it has no impact on the pregnancy outcome. So I just wanted to add on to what Nalini has said.
Right.
Yeah, and I would also like to add that except for subclinical and clinical hypothyroidism, I don't really believe that I would do any of the other tests.
Yes.
Absolutely. Okay, which therapeutic intervention should be offered to couples with unexplained RPL to increase live birth? Kiran, I think you can take this question.
When we come to unexplained RPL, there is always there is a googly in that. There must be some or other reason we should try to find out. But as we have listened in the previous lectures that we can do the endometrial scratchings or giving this PRP or this can be done for as interventions for this improve the live birth rate, low molecular weight heparin or this lymphocyte immunization therapy. These are also having definite role in unexplained RPLs.
Absolutely. So, if you look at these recommendations, they are as what is seen in the slide, where it is said that vaginal progesterone does not improve live birth weights in women with unexplained RPL. There is insufficient evidence to recommend intralipid therapy. There was a question asked by somebody about this for improving live birth rate in women with unexplained RPL. And in fact, lymphocyte immunization therapy should not be used as a treatment for unexplained infertility, as it has no significant effect and there may be serious adverse effects. Anjali, which therapeutic intervention should be offered to couples with RPL and thrombophilia to increase live birth rates?
Usually, we prefer to give aspirin and low molecular weight heparin in these patients. Combined effect, and some people add immunoglobulin also.
Okay.
But aspirin and low molecular weight heparin is preferred.
Right. So, what the literature is saying is that for women who fulfill the laboratory criteria of APS and have a history of three or more pregnancy losses, we suggest administration with low dose heparin, 75 to 100 milligrams per day, starting before conception, and a prophylactic dose of heparin. Right. So, to conclude, these are some of the key messages that we would like to give. But before I end, just one quick comment from each participant, one take-home message, starting with Lakshmi.
Yeah, all said and done, whatever extensive evaluations we do, 50% cases do remain unexplained. So your tender loving care in all the cases of RPL is going to make a tremendous impact on the outcome of the pregnancy.
Right. Anaita?
I just want to put a word of caution that people are unjudiciously using low molecular weight heparin, aspirin and progesterone for all cases, and this should be avoided, especially the low molecular weight heparin. You should think before you start.
Okay. Nalini?
Karyotyping is also, instead of karyotyping, microarray is useful test for POCs. Instead of instead of karyotyping, microarray should be done on POCs.
Right. Anjali?
If a case of incompetent os, so we should not wait till the patient gets shortened length. Sometimes we have to do the cerclage even after NT scan at 11 to 12 weeks, because we have seen lots of patients suddenly comes with abortions.
Right. Kiran?
I want to tell that though the definitions of RPL contains 2 or 3 losses, I think every pregnancy is precious. So if with one loss also we should start investigating, and we should give psychological support. That is also very important.
Right. Nilesh?
I think all RPL cases should be investigated, and we should know which investigation to do in which kind of patient. So suppose if a patient, we should say always no to torch testing, but if suppose a patient has RPL of more than 10 weeks, then the investigations will be more so immunological and thrombophilia related. If the RPL is less than 10 weeks, we should think of septate uteri or anatomical causes as the cause. So it should be categorized.
And
Absolutely. And Rohan, last
so
comment from you.
yeah, definitely. One thing I agree was with everyone, and especially with what Dr. Lakshmi Srikhande ma'am said, tender loving care is one of the most important things you can give to these patients of RPL. Proper counseling is required, and anyone with recurrent RPL with genetic factor being responsible, PGS and PGT can also be considered for these patients for future pregnancy as well.
Parag.
Right. Right. Yes, Chaitanya.
Yeah, actually, one question from my side is when do you advise IVF in RPL patients? Because if you ask,
Chaitanya, I'm sorry, I didn't get the question.
yeah, but what is the indication for IVF in RPL patients?
Okay. Nilesh, you want to take that?
Yeah, I can take it as up. So basically, all those patients where we have found out a genetic cause, if we have done a microarray of that patient of the POCs, or if a CVS was done in the previous pregnancy and it was abnormal, so for these patients, we will like to do IVF. Basically, not post the patient for natural conception. We'll go for the embryo formation and do embryo biopsy in the form of PGTA if the detection was not done of the genetic material. If there was a specific single gene defect, we'll go for PGTM, and if there was a translocation, we'll go for a PGTSR, or structural rearrangement. PGT for structural rearrangement.
Right.
And then
All right. So, yeah. So, just to conclude, we all agree that recurrent pregnancy loss is a heterogeneous condition, and there are many possible causes. There could be one or more factors which could be responsible for a loss in a particular patient, and each RPL may have a different cause. So each RPL may have a different solution. So we have to keep in all these things together and then do whatever is best possible for the well-being of the woman. So again, on behalf of myself and the organizers, thank you all the panelists for being here and giving us nice practical tips. And thank you team Amogs, Chaitanya, Nandita and all for having all of us here. Thank you.
Thank you, Parag, for wonderful moderation.
Thank you, Parag.
Thank you so much, Parag sir. Thank you, Chaitanya sir.
Thank you,
Nilesh
Chaitanya
sir,
sir.
for including me in this
Thank
program.
you. Thank you.
Thank you all.
Parag, for the wonderful panel. It was really practical based, and take-home messages were very much in your panel discussion. Thank you all the panelists for wonderful interaction.
Thank you.
We come to the end of this session. I would like to thank all the chairpersons. I would like to thank the moderator Parag sir for a wonderful session as always. I would like to congratulate and thank all the panelists. Lastly, but I would like to thank Amogs, Dr. Chaitanya sir, Dr. Nilesh sir for giving me this opportunity. And now I would like to uh, invite Dr. Nilesh sir to give away the vote of thanks.
Thank you all the panelists, all the esteemed faculty, guest of honors, Dr. Nandita madam, Dr. Rishma madam for being present throughout this session, majority part of this session, and all the societies of Amogs, so lovely societies, and we have 8 societies and 8 presidents guiding us all throughout all this session. I would like to thank Chaitanya Shembekar sir, Chairperson Infertility Committee Amogs. Um, Not the least, I would like to also thank Ameya for conducting this session so beautifully well, and Bharat Serums for being the academic sponsors for this event. Chaitanya sir, over to you. Anything, last comments from you? Thank you.
Really, it was a wonderful session and attended by so many delegates. And thank you all for this wonderful panel and all the speakers for their inputs on how to do the practical aspects of RPL. Thank you so much. Thank you, Nilesh and Rohan. You are my right hand and left hand, so you are always there with me. Thank you, Rohan. Thank you, Nilesh, and thank you all. Thank you, Parag, for a very nice, wonderful panel. Thank you all. Thank you.
Thank you all.
Thank you all. Good night.
Good
Bye.
night.
Good night.
Bye bye. Thank you.
Thank you, doctor.